Hello everyone, my name is Jessica Reed. This presentation is going to discuss my DNP project, Infant Safe Sleep, Improving the Discharge Process, that I completed this summer to graduate with my doctorate of nursing practice from Maryville University. These are the committee members that were invaluable throughout this process. The Scholars Faculty Chairperson, Dr. Tanya Crystal from Maryville University. Community member Jessica Hanna, who is the Quality and Safety Director of the unit that the project took place in. And the second reader, Dr. Rita Wunderlich from Maryville University. So currently, safe sleep recommendations are the following. Infants should be lying supine for every sleep. They should use a fitted sheet, a firm sleep surface, room sharing with no bed sharing, no soft objects or loose bedding in the sleeping areas to reduce the rate of SIDS, suffocation, strangulation, and entrapment. Consider the use of offering a pacifier at nap time and at bedtime. And avoid the use of commercial devices that are inconsistent with safe sleep practices. Despite the American Academy of Pediatrics releasing these recommendations in their Back to Sleep campaign in 2016, 22,341 infant deaths related to sleep were reported in the U.S. in 2017. And while some parents are receptive to safe sleep education at initial discharge from either the newborn nursery setting or the neonatal intensive care unit, there is a lack of follow-up, check-in, and education as providers treat patients in the outpatient setting from 0 to 12 months of age. This presents a huge problem. There has to be more established and consistent education techniques among nurses to ensure parents are given the information to follow safe sleep recommendations at home to protect our pediatric population. This scholarly project specifically aims to increase the number of parents with infants 0 to 12 months receiving safe sleep education from nurses in the outpatient setting. With safe sleep practices, utilizing a standardized teaching tool and ensuring it is taken home with parents, as it includes references to videos and other important resources, may increase nurse compliance with safe sleep education at discharge. This standardized teaching tool used for this project is a pamphlet that will be added to discharge paperwork for education prior to leaving the hospital on the day of surgery. Overall, the intent is to ensure parents are well educated about safe sleep practices, as this is another step closer to reducing the rate of SIDS related to sleep. The PICO question developed for this project was for registered nurses on an outpatient surgical pediatric unit. Does the implementation of a standardized teaching tool regarding safe sleep within the discharge paperwork compared to the use of no standardized teaching tool increase education compliance documented in the electronic medical record to parents with an infant 0 to 12 months at the time of discharge? This PICO question was used to conduct a literature review through Maryville University's library databases. This included Academic Search Complete, Cochrane Database of Systematic Reviews, Cumulative Index of Nursing and Allied Health Literature, EBSCOhost, Medline, and PubMed. Following this search, 16 articles were chosen for analysis in this integrated literature review. These articles address 3 themes: safe sleep recommendation, parent education, and nurse barriers to providing education. We addressed this earlier, but as a refresher, the AAP presented the Back to Sleep campaign in 2016. This included placing infants on their backs to sleep, putting nothing in the crib aside from a fitted sheet, and no co-sleeping to reduce the rates of SIDS. Additionally, they can use a pacifier at nap and bedtime, breastfeed, avoid smoke exposure, and receive routine vaccinations to help decrease that SIDS rate. The Center for Disease Control and Prevention, or the CDC, released a statement to verify the AAP's safe sleep recommendations further, stating they also suggest infants lay supine, sleeping on a firm, flat sleeping surface with only a fitted sheet, no blankets or toys in the bed. There was an overwhelming agreement within the literature that these guidelines stand as best practice, but that there were various barriers to compliance that needed to be addressed. This included things like cultural ideology, different routines depending on who is putting the child to sleep. So this could be a difference between mom and dad at bedtime, grandparents, babysitters, split custody situations where mom has the baby one night, dad has the baby another night, and this just disrupts that routine of safe sleep habits for the child. Another potential barrier is solely relying on cardiorespiratory monitoring during sleep. We know that the owlets and pulse oxes are very common these days for infants to have, and parents feel that they don't need to put their baby back to sleep because those monitors will inform them if there's an issue. And lastly, a fear of aspiration that is very common among parents with newborn infants. They feel that their baby cannot protect their airway on their back, so they need to turn them on their side or on their belly to sleep at night to reduce that risk of choking. Moving on to the next theme, there was an overwhelming positive correlation between parents who did not practice safe sleep with their infants and their feelings of inadequate and inconsistent safe sleep education from healthcare professionals. Parents who felt well educated and equipped with proper resources to take home for reference to safe sleep habits implemented those habits with their infant. And furthermore, parents feel empowered to implement safe sleep practices with their infant when they feel adequately prepared to do so with that education. This indicates the need for consistent and standardized approaches in the healthcare system when tackling safe sleep education. And the last theme addressed the importance of identifying nurse barriers to providing this education. RNs are the primary source of discharge education for newborns before leaving the hospital. One study specifically analyzed the implementation of a safe sleep policy within a single postpartum unit. RNs provided safe sleep education at discharge only 52% of the time due to a lack of education themselves, lack of time, and or a lack of resources. Additionally, there's confusion surrounding the AAP recommendations and the possibility of policy changes throughout an RN's time at bedside. Standardization in continued education and practice techniques surrounding safe sleep could improve nurse compliance, according to the literature. These articles reviewed showed no evidence of plagiarism, falsification, or fabrication. Most of the studies noted that they received proper approval to conduct their studies from a research committee, quality improvement board, ethics committee, institutional review board, or they had met the legal requirements within the institution of practice. And additionally, large sample sizes and randomizations were used for most studies, and these all serve as strengths to the literature. For weaknesses, several of the studies use self-reported behavior to make conclusions about their research, which can create issues in reliability of that information, and the demographic of the patients or of the participants was limited in some of the studies. So while safe sleep education should include both the mother and the father's views, beliefs, perspectives, and or guardian, whoever is the sole caretaker of the infant. Several studies only focused on strictly the mother's beliefs, feelings, and practices on safe sleep with their infant. For this project, Hildegard Plow's interpersonal relations theory was integral in the theoretical framework. So this framework suggests that the interaction between the nurse and the patient directly impacts qualitative outcomes for patients. The purpose of this theory is to instill an understanding that the nurse-patient relationship should be the foundation of our nursing care. It presents us with direct effects on the outcomes of our patients, as the therapeutic relationship promotes the patient's self-awareness, personal identity, and individuality, which are the guiding concepts for nursing. It has 3 phases: the orientation phase, the working phase, and the termination phase. During the orientation phase, hospitalized patients realize they need help and attempt to adjust to their current and often new experiences. Simultaneously, nurses meet patients and gain essential information about them as people with unique needs and priorities. The next phase is the working phase, in which nurses make assessments about patients to use during teaching and when contributing to the interdisciplinary plan of care. Finally, the termination phase depends on how well patients and nurses navigated the orientation and the working phases. A major part of the termination phase occurs when the nurse teaches patients about symptom management and recovery at home. And for this scholarly project specifically, parents would begin the orientation phase when their child is born as they learn to navigate safe sleep practices with an infant. The working phase would be the development of that nurse-patient relationship, and as the nurse cares for the parent and the child, the nurse can offer advice and suggestions and evaluate the best teaching methods for the parents. And lastly, the termination phase would take place at the time of discharge when the nurse is providing the parents with that education and support for home care. Now to discuss methods and design. So after committee approval from Maryville University and the Department of Clinical Quality, Safety, and Excellence at the chosen facility, the scholar received a written list of patients who received care on the outpatient surgical unit between July 3rd and August 14th, 2023 from the nurse manager. This accounted for both pre-intervention and post-intervention data, along with a temporary password to access the EMRs temporarily. Using a quality improvement exploratory retrospective chart review design with a collection of descriptive quantitative data, the scholar was able to use a convenience sample taken over a 2-week period. That 2-week period was July 3rd to July 17th, 2023, for comparison and assessment of the effectiveness of the educational intervention. There was no active patient participation or patient identifying factors noted within the data aside from being a part of that 0 to 12 month age range. 77 EMRs were examined for pre-implementation data. Then the scholar audited safe sleep education given by the RNs in the EMR for patients 0 to 12 months of age that received care on the outpatient surgical unit from July 17th to August 14th, 2023. 77 EMRs were examined for post-implementation data as well. And for a better understanding on why a retrospective chart review was used, RNs on the unit can chart specific education given within the patient's EMR. So the scholar was looking specifically for RN charting that stated safe sleep education was given to a parent or guardian with the standardized teaching tool at the time of discharge. This project was implemented in an outpatient surgical unit at a children's hospital located in the Midwest region of the United States. All infant patients 0 to 12 months of age receiving care on the outpatient surgical unit during the project timeframe, July 3rd to August 14th, 2023, were reviewed for potential inclusion in the retrospective chart review. Inclusion criteria included documentation that the infant is 0 to 12 months of age, that the infant received care on the outpatient surgical unit during the project's timeline, and that there was documentation whether the RN did or did not provide safe sleep education to the parent or guardian at the time of discharge within the EMR. Exclusion criteria included documentation that the infant was over 12 months of age, the infant was not receiving care on the outpatient surgical unit during the patient's time frame, or if the infant had met a medically complex diagnosis that would contradict safe sleep regulations. So this could be the need for oxygen at night, head of the bed needing to be elevated, artificial airways, or the need for suction. For RNs, they had to be employed on the participating unit and provide discharge education during the project timeline. For data analysis, a total of 154 charts were reviewed by the scholar, with the data collected via a chart that stated yes, no, or patient refused education as it was electronically charted by the RNs that discharged the infant. So there was a ratio out of 77 for each of those categories. The data collected to examine the trend in the unit change over 6 weeks was analyzed by using the z-test for the difference of two proportions with a level significance of 0.05, as suggested by the Maryville statistician, Dr. Mark Pals. The z-test for correlated proportions is applied to investigate the difference between two correlated proportions, and the null hypothesis suggests that the proportions are the same, while the alternate hypothesis suggests that the proportions are different. Before implementing this quality improvement project, privacy protection and measures to avoid unethical conduct were established. The program provided the scholar with education on compliance with the expectations and regulations of the IRB, HIPAA, informed consent, and ethics in research. So as mentioned a couple times before, 77 EMRs were reviewed for pre-implementation group and 77 EMRs were reviewed for the post-implementation group. The achieved power for this project was high in strength at 0.999. The z-test for the difference between two proportions was used to determine the statistical significance between the pre and post-intervention number of RNs that provided safe sleep education at the time of discharge from the outpatient surgical unit. This test indicated statistically significant differences in the education provided by the unit RNs when given a standardized teaching tool to include in the discharge paperwork for their infant patients. The p-value of less than 0.001 is less than the significance level of 0.05. There is sufficient information to suggest that increased education compliance from pre to post intervention. A confidence interval was calculated using a confidence interval of 95%. The confidence interval suggests a true change in the ratio of education given between the pre and post implementation groups. This is shown on the graphs represented on this slide. There were limitations to this study. First, although the literature review revealed that a standardized teaching technique increased education compliance among healthcare professionals, there was limited data on implementing a standardized process and what that really looks like and how to be successful in a certain or particular avenue. And while several studies or several articles implemented educational programs for RNs to standardize safe sleep practices, there was little discussion on continuing these programs after initial implementation, and the implementation needs to be a continuous process for actual progress to be made. Also, education techniques among RNs vary, and those who have been practicing for years have hesitation or refusal to adapt or change their process. It was challenging for the scholar to address and educate these employees on the importance of embracing the project implementation to improve patient care. And even with various attempts at open communication between the scholar and the unit RNs that were resistant, some refused to participate and limited the sample size for the project. And finally, even if parents verbalized understanding of safe sleep education and took the standardized teaching tool home at discharge, no one could observe if they provided their infant those safe sleep habits at home. And ultimately, that is what truly will reduce the rate of sleep-related sudden deaths in infants. The expected outcome was that implementing a standardized teaching tool at discharge would increase RN safe sleep education compliance for parents of infants 0 to 12 months during that 6-week period that the project took place. The findings were authenticated by increased documentation of our RN safe sleep education within the EMR over that time period. Pre-implementation education documentation was at 30%, and post-implementation education documentation was at 75%. These results are a step closer to reducing SIDS rates related to sleep through increased and continued education. For implications to practice, the scholar examined them in 3 areas: clinical practice and future research, healthcare policy, and quality and safety. For clinical practice and future research, safe sleep education requires continued parental education through the first year of life. Healthcare professionals in the outpatient pediatrics are responsible for providing this education, instilling confidence in parent practice, and fostering an environment that promotes the trust and well-being of the infant patient and their family. With the help of a standardized teaching tool to include with the discharge paperwork, there was an increase in safe sleep education given by RNs and education compliance documentation within the EMR. Future practice and studies can be enhanced by a more profound exploration of hesitations and refusals surrounding infant safe sleep practices. And in regard to healthcare policy, RNs must have a standardized protocol in place to provide safe sleep education to parents of infant patients. The inpatient and outpatient pediatric setting remains a secure space for continued infant education following initial newborn discharge from the hospital. This quality improvement project implemented a standardized protocol to provide safe sleep education when one did not exist within the unit it took place. And lastly, for quality and safety, this project's mission encompasses promoting infant safety related to sleep. The goal is to reduce the rate of sleep-related infant deaths by ensuring parents are well educated with proper resources to initiate evidence-based sleep practices at home. A standardized protocol within the pediatric outpatient units that outlines the quality interventions and safety recommendations to RNs to provide a parent at discharge is essential. This allows RNs to ensure that parents have the necessary resources and confidence to continuously improve their infant's quality and safety while at home. Due to a standardization process, this project revealed increased RN safe sleep education compliance to parents of infants 0 to 12 months, and education was successfully documented by RNs within the EMR to objectively show the use of the standardized teaching tool, which was available to parents when leaving the unit. This will equip parents with the research and resources needed to evaluate, adapt, and change their sleeping habits to reflect evidence-based practice if necessary. Collaborative studies within the literature found that parents are more likely to engage in safe sleep practices at home when they trust their healthcare providers to give the information and education and resources and have resources readily available to continue learning these safe practices. Additionally, studies showed that implementing a standardized process regarding education increases compliance among RNs at the time of discharge. To improve outcomes in future studies, it would be helpful to enlist a follow-up period with parents to see if education given at discharge influenced them to implement safe sleep practices with their infant at home. This would gauge education retention and its impact in reducing sleep-related infant deaths. I am now open to answering any questions anyone may have regarding the project or research behind it. Please reach out to me via the email listed on this slide, and I will be happy to answer any questions you may have. And here are my references, and I thank you so much for taking the time to listen to me.